Hi, good evening, everyone. Can everyone hear me okay? If so, feel free to pop in the chat that you can hear me. Okay, brilliant. Thank you. So we'll make a start. So thank you for coming to the fourth session of our surgical teaching series with Bite Medicine. So we're doing urology today. And in case it's the first time that you've come, my name's Adan. I'm one of the F1 doctors currently working in Royal Stoke as an SFP trainee. And just a bit of background about myself. I did kind of the MLA trials last year as a part of my medical finals. So I feel a bit more, I feel like compared to my peers, maybe I would feel more kind of familiar with the MLA content. So yeah, we'll be covering some SBAs tonight. And just to start off with, I'd like to thank Bite Medicine, which is an online education platform that's had a recent update on its question bank and its textbook. So it's a great kind of question bank that involves a lot of case-based questions as well as single best answer questions that you can get in both exams, which I found quite useful in my finals study as well. And the online textbook, which has also now been updated, contains around 600 plus articles, which are freely editable, which is great because you can use it as your own notes and improvise kind of or emphasize certain aspects of your studying that you keep missing out. So I think that's quite useful. And you can also edit graphs and the text as well freely. And there's a free component and there's also a premium component that obviously people who want to pay will get more out of it. But I personally find it really useful for my studies and finals. So I would definitely recommend kind of if there's anything you didn't understand or anything you want to supplement from today's session, have a read in the online textbook. That would be quite useful as well. So just to start off with, to kind of go through what we're going to cover in this session, we're going to do kind of some common urological presentations, such as the malignancies, the common emergencies, some of the presenting complaints, and some of the very high yield conditions that we'll focus on. And by no means this is an exhaustive list, but I hope like through this session we'll be able to signpost you with a few common concepts that come up in your exams and finals. And we're not covering anything medical today, so it will be mostly kind of surgical conditions, not much about AKI, CKD, dehydration, diabetes, that sort of things. That'll be more kind of a nephrology, renal medicine based. So hopefully this session will last about an hour. With the previous experiences, sometimes we have a bit of a discussion on some questions so that we might go over time a little bit, but feel free to participate in the discussion because I feel like this is really useful and helpful for you guys to kind of apply your knowledge. So I'd also like to encourage you guys to join the Menti meter. That's if you put in the code, go to menti.com, put in the code, I will start the session. I believe I've already started the session. Yeah, if you guys go to the menti.com and put in that Menti code, you should be able to participate in the questions as we go along. And I feel like that would be quite useful for you to get some practice and get into that final mindset if any of you are final years. And also some slides, recordings, and everything will be uploaded on the Bite Medicine website. And also hi to those who are streaming from the website. So kind of the general structure of today's session will be we'll attempt several SBAs at the start, and then we'll come up to a top decile question for anyone who's aiming to fly high, and we'll end with a couple of rapid fire questions to get us thinking and our medical instincts on point. And feel free to stop and discuss any questions and put it in the chat if any of you want to do so. So we'll make a start for our first SBA question. Is everyone able to see the slides okay? Let me know if you can't, and let me know if there's any issues with the Menti, because from my side it should be all working. Okay, so the first question is about a 42-year-old woman who presents to the emergency department with left-sided loin to groin pain, which is colicky in nature. She's not able to sit still in the emergency department because of the pain, and on examination, she looks quite unwell, and she's complaining of some pain in her left flank, and she feels nauseous. Her obs are stable, and she's not feverish. So you can see that her dipstick in her notes indicates trace bloods. A CT-KUB shows a 7mm left mid-ureteric stone. So, which of the following is the most common composition of a renal stone? Would it be struvite, calcium phosphate, cysteine, calcium oxalate, or uric acid? Just going to give you guys a couple minutes to think about the answer. One second, someone's just asked for the Menti code. So I'm going to copy it. Just 1 second. I've just put it in the chat. Okay, I think there's quite a divide of answers, but I think most of you got it correct. The correct answer is calcium oxalate. That's the most common type of renal stone. Other types of renal stone exist, and we'll talk about it on the next slide. Well done to those of you who got it correct. So in this slide, we'll be kind of going through the concept of renal calculi, which is, I think, quite a common concept that will appear in your exam. So how it forms, it's basically calculi are crystal aggregates that form in the urinary tract. And because the urinary tract isn't exactly designed to have some solids stuck in it, so it causes severe pain when there's peristalsis in the urinary tract. And that's where we get the renal colic pain from, the kind of waves of loin to groin pain. That's quite severe in nature, is usually as a result of calculi. Patients usually look unwell, nauseous, they can't sit still because of the pain. And that's evident in the previous kind of question stem that we looked at. So different types of stones. We've got calcium phosphate, we've got calcium oxalate, which is the most common type, and also the answer to our question. We've got struvite stones, which are mostly linked to Proteus and urea plasma infections. And that also classically causes a staghorn calculi, which is very obvious because you can see the kidneys on the CT and a very bright kind of staghorn-like stone that's stuck in the renal pelvis, and that's usually a struvite stone. And you can also have cystine stones, which is linked to conditions such as cystinuria, which are genetic conditions, and renal tubular acidosis. It causes a ground glass appearance on radiographically. And there are also urate stones, which are linked to hyperuricemia or gout. So the reason why I put those stones in that order is because they appear, the higher up the stones are, the more radio opaque they are. So they'll appear more white on a CT or an X-ray. And the lower down the stones are on this list, it's the increasingly radiolucent. So they'll be gray or black in color, which make them a bit more difficult to visualize on a CT X-ray. So sometimes you really need to take into your account your clinical skills and the kind of the clinical context of that patient and how they present to diagnose these renal calculi. But the most important thing is knowing that calcium oxalate, which is very radio opaque, is the most common type of stone. And also being aware that there are other types of stones that exist as well. So that's it for the first question. Not sure if anyone has any questions. Feel free to drop them along the chat, and I'll address them whenever we get kind of a breather. Okay, so we'll move on to the next question. Oh yeah, one more point is that stones can also be mixed. Commonly, calcium oxalate and calcium phosphate stones can be mixed, but they'll also appear radio opaque on the CT. So question 2, I'll change the Menti slides. So the question 2 is about a 55-year-old man who mentions he's got some urinary symptoms, very embarrassingly, for the past 2 months. He feels the need to pass urine more than usual and is often slow to initiate urination. Sometimes the stream feels a bit weak as well. He drinks several cups of coffee a day at work, admits to a very poor diet, which has also resulted in constipation. So you do a PR exam and you can feel a smooth and enlarged prostate on rectal exam. Urinalysis is normal, but you can see that his PSA is very mildly elevated. What would be the most appropriate management option here? Would it be lifestyle advice and bladder training, starting him on finasteride, starting him on oxybutynin or tamsulosin, or would you schedule him in for a transurethral resection of the prostate? Couple more seconds for those who want to participate. Okay, so correct answer here would be lifestyle advice and bladder training. We'll talk a bit about kind of how to initiate what type of management in patients with benign prostatic hyperplasia, which is the most likely diagnosis given the STEM. So finasteride and tamsulosin are both used in BPH, but we wouldn't really want to medicate that patient in this case because he's not super concerned about it. And obviously, when you initiate someone on the medications, there's also the side effect profile that you would need to consider. A TERP for this gentleman could be a possibility, but it's usually reserved as the last line when they're not really responsive to medications, or there are other more complex issues that contraindicate medication use or conservative management. Oxybutynin wouldn't be used in this case. It's usually used more in women and incontinence in women. So we'll talk a little bit about BPH. So there's three managing different conditions. Also, we usually talk about three main kind of pillars, mainly conservative, medical, and surgical management. Conservative management, you would start with this because it has no side effects. And it causes a minimum kind of disruption to the patient's kind of physiology. So how would you manage someone with BPH conservatively? You would reduce their fluid intake, especially with caffeine and alcohol, which this gentleman takes a lot. Encourage them to double void. So when you go to the loo, go twice. And bladder retraining exercises. Medical management is usually reserved for more slightly bothersome cases, but there are no indications for surgery, which I'll cover on the next slide. First line, we usually use tamsulosin, which is an alpha-1 antagonist that relaxes the smooth muscle in the prostate and the bladder neck, which alleviates those urinary symptoms. There are also side effects to consider, sometimes postural hypertension, dizziness, dry mouth, depression, which is probably not the best in a very frail elderly person. You wouldn't want to kind of put these side effects on them unless there's a very good benefit to them. The second line would generally be 5 alpha reductase inhibitors, also known as finasteride. They're more hormonal, and because of that, they take a little bit longer to work. They inhibit DHT formation, the testosterone formation, which reduces prostate size and hopefully kind of slows the progression and the symptoms of the BPH. So obviously, with hormonal therapy, you can get kind of sex hormone related side effects such as a reduced libido, erectile dysfunction, reduced ejaculate volume, and gynecomastia. And if it's severe, you can also try phosphodiesterase 5 inhibitors, also known as sildenafil. But that's usually used for very severe cases. There's also the International Prostate Symptom Score. If anyone wants to read up about it, it's like a scoring system to classify how severe the symptoms are for BPH. So if anyone wants to, just as a reference, have a look at. So there are some surgical options. There's TUIP, transurethral incision of the prostate, where a resectoscope is inserted into the ureters, and they'll kind of remove parts of the prostate using diathermy, and then you wash out the parts. So you can sometimes get sexual dysfunction, but it's usually at a lower risk. The second option is quite kind of well known, transurethral resection of the prostate, which is a TURP. and then a rectoscope is inserted into the ureters, and there's a washout of the parts that you remove, and there are also sexual dysfunctions, which is you're at a higher risk of it because obviously it's a little bit more invasive than the above. And there's also open prostatectomy, which is for complicated urinary systems and very large prostates. And you would approach it suprapubically, so in the stomach. And there's also a higher risk of sexual dysfunction. Indications for surgery, there's a common acronym, rushes, that we can use. So any recurrent or refractory urinary retention, so anything recurrent or refractive to treatment, any recurrent UTIs, any bladder stones, any hematuria, elevated creatinine, so that could be linked to AKIs due to bladder outflow obstruction, or symptom deterioration despite kind of medical management. So these would be indications that you will want to refer a patient for surgery. So well done to those of you who got the question correct, by the way. So we'll move on to the third question. So this is a 19-year-old male that's been experiencing excruciating pain in his right testicle that came on suddenly during a rugby game after a big tackle. The patient vomited twice and he's not sexually active. On examination, the right testes is red, swollen, tender, and retracted. The pain is not relieved by lifting the testicle, and the testicle does not trans-illuminate with light. The chromosteric reflex is lost as well, and his observations are very stable, besides from slight tachycardia. So what's the most likely diagnosis in this gentleman? Is it renal colic, a hydrocele, testicular torsion, a strangulated inguinal hernia, or epididymolysis? So I'll give you guys a few seconds to, hopefully this is a very straightforward question. Okay, yes, so everyone's got it correct so far. It is testicular torsion. It's a very classic history, and it's not something that you want to miss. Otherwise, there'll be kind of severe consequences. Obviously, there are nice other differentials to consider, such as a hydrocele, but it says that the testes did not trans-illuminate with light. Epididymolysis is also a reasonable differential, but it's usually more subacute and doesn't start as an acute as a torsion. So brief overview of the features, which I hope you guys are already quite familiar with. I believe it's so I'll just go through it really quickly. So I've highlighted kind of the cues to pick up, and I think it's quite important when you're taking a history to focus on these cues as well, such as severe pain, it being unilateral, sudden onset, nausea and vomiting, red swollen tender testicles, retracted testicles, Pren sign negative, which is pain relieved on lifting the testicle, and the chromosteric reflex, the loss of the chromosteric reflex. So the management would be urgent surgical expiration, orchidopexy, which is where both testes are usually fixed to the posterior wall of the scrotum, and usually both are done at the same time. Excuse me. And orchiectomy, which is the removal of the testes, is sometimes done depending on kind of what the patient wants. There's also something called the bell clapper deformity, which is a risk factor to torsion, which is how kind of the testes are arranged, and it's usually a congenital kind of physiological variant that puts someone at an increased risk of torsion. Does anyone have any questions? Otherwise, we'll probably move on to some more complicated concepts as we continue. So if anyone has any concerns about kind of what we talked about, please feel free to drop me a message. I assume not, but always you can leave it on the chat anytime. Okay, so we've got the fourth question, which is a 78-year-old female who presents to the emergency department with visible hematuria and right loin pain. Her temperature is 37.3, her pulse is 72, which is normal, and her blood pressure is 165/107. You can palpate masses in both flanks. So some investigation, she's slightly hyponatremic. She's a little bit hypokalemic, and her creatinine is very high. Her urinalysis shows blood 4+, protein 2+, and leukocytes 3+. What is the most kind of appropriate next investigation? Would it be an ultrasound of the kidneys, ureters, and bladder? Would it be a sigmoidoscopy? Would it be a CT-KUB? Would it be a flexible cystoscopy, or would it be an abdominal X-ray? Just a couple seconds for people to give it a go. Okay, I think approaching this question involves kind of thinking what is the most likely diagnosis and also what's the best modality. There's a mix of answers between ultrasound and CT on the Menti, but the correct answer is actually ultrasound. So this patient, I don't think this concept is very well taught at medical school, but this patient has a urinary tract obstruction. And ultrasound KUB is almost always the best kind of initial imaging for this, because it's fast, it's quick, it's usually more available, and it's less costly than a CT-KUB. A CT-KUB is probably better for cases such as renal colic, or it's probably more reasonable for a case of renal colic where you get classical loin to groin pain, as we spoke about earlier. So I'll briefly talk about urinary tract obstruction, which is an emergency that you guys should be able to pick up. And broadly, it's divided into two main categories. So you can get upper tract obstruction and you can get lower tract obstruction. So features like renal insufficiency that is unexplained, decreased urine output, or there's some sort of pain that suggests obstruction. And then this or oligoanuria, with kind of polyuria. So in this patient, we can see that she's obstructed bilaterally because we can feel flanks in both. We can feel masses in both flanks, and there's some sort of AKI going on. And we would need to be able to distinguish kind of if it's upper tract or lower tract obstruction. So I'll go with upper tract first. Some of the causes are congenital abnormalities and renal calculi, which is possible in this case. And always the initial kind of diagnostic imaging would always be ultrasound, because it's usually a bit more available than a CT. But I would agree, a CT is something maybe you could do later on in the further down the line, before an after an ultrasound, sorry. And yeah, you can, in these cases, we would always like to involve urology, because it's clearly a very complex case of bilateral kind of hydronephrosis query. In terms of lower tract obstruction, some of the causes would be BPH, and the initial management would be attempt to catheterize the bladder or cystourethropy, and also consider voiding cystourethropy. You would also involve urology in this case. Any questions at this point? What exactly are the masses? Yeah, we've got a question asking what exactly are the masses being felt on the flanks. So in this case, what I was thinking was probably kidneys that are very severely hydronephrosis. So severe hydronephrosis, when there's obstruction of some point in the urinary tract, fluid gets kind of backflow, and there's a huge traffic jam per se coming that causes the kidneys to swell up, which causes the hydronephrosis. And in clinical practice, you see kind of ultrasound KUB ordered quite frequently to rule out such a diagnosis, because it is an emergency. I hope that answers your question. Okay, so we'll talk about kind of the management now. Obviously, the aim of the management is to relieve the obstruction promptly, especially if patients have UTIs. So upper tract obstruction, the principle would be using the cell dinger technique, which is where a lot of kind of medical surgical management comes from. So it involves kind of an insertion of a guide wire and then a tube over it. So you can guide kind of the insertion of the tube into the right place. There's percutaneous nephrostomy. So you basically poke a hole in the skin in your flank that goes into the renal pelvis that allows you to drain the obstruction. There's also ureteric stent insertion. So you go from the urinary tract from bottom to up into the ureters. It's also called a JJ stent for some reason. So for lower tract obstructions, you would always kind of try from the basics. Foley catheters are the ones that you put in medical school. They get you signed off for those. They're most commonly seen on the wards. You could try putting in a Foley catheter. Sometimes it's quite difficult. So you can use a Coud tip catheter, where it's a little bit different from the Foleys in terms of that the catheter tip is a little bit curved upwards. So there's more direction and gives you a bit more kind of leverage to put the catheter in. Sometimes you can get varying sizes of those as well. And it's kind of like a cannula. The higher the number, the smaller the diameter of the tube, which makes it a bit easier to put in. And obviously, if that fails, if a Q-tip catheter fails, you would think about suprapubic aspiration or catheterization, where you make an incision directly in the suprapubic region of your stomach, of your tummy, and then you put kind of a needle or a catheter to drain the urine directly. Obviously, you would involve urology, as I've said. Okay. So coming on to the 5th SBA, we have a 67-year-old gentleman who's seen by his GP, as he has noticed that his urine does not flow as well as it used to. He reports some urine dribbling out after he's finished, and he's known heart failure, smokes 10 cigarettes a day. He has had no previous surgery and lives alone and is independent. So he gets an examination and a lot of investigations. And after that, he's finally diagnosed with prostate cancer with a Gleason score of 6 and a CPG 1. What is the most kind of appropriate management option for this gentleman? Would it be active surveillance? Would it be radical prostatectomy with pelvic lymph node dissection? Would it be radical prostatectomy without pelvic lymph node dissection? Would it be chemotherapy with docetaxel with anti-androgen therapy? Or would it be radical radiotherapy or brachytherapy? Couple minutes to think about the question. Okay, so a few of you have gone for active surveillance, which is the most popular answer, and 1/3 of you have gone for radical prostatectomy without pelvic lymph node dissection, which is well done, the correct answer. So we note in this case that this patient has a low-grade tumor, and he's also quite an active male who's independent. He's also fairly young. So although active surveillance is not a bad choice for someone who has a low-grade tumor, but because this person likely has more than 10 years of life expectancy, we would like to treat it a little bit more aggressively. And because this patient is quite fit and well, usually it means that they will be fit for surgery. The other options are reserved for more kind of aggressive tumors and high-risk tumors. So we'll talk about kind of the patient journey of diagnosis of prostate cancer on the next slide, which I will cover, which is a bit longer. So when a patient presents with signs and symptoms suggestive of prostate cancer, it could be anything from urinary symptoms. The GP would like to examine them with a PR exam or check their PSA. And if in a DRE, the prostate feels a bit malignant, so hard and craggy and an irregular mass, or the PSA is above normal limit. Just bearing in mind that the PSA normal limit depends on your age. I think it depends on which decade of you in your life are. So if that's above the normal limit, you would refer them for a 2-week wait, suspected cancer pathway, which the first line investigation would be a multi-parametric MRI. If that's negative, you would have a 3 to 6 monthly surveillance of the PSA and then re-refer as appropriate. Or if it comes out of a Likert scale 3 or more, which refers to the Cambridge prognostic group, or the patient wishes, then you would undergo multi-parametric MRI influenced biopsy. Sorry, the Likert scale is a different kind of grading than what we use to grade tumors, which is what follows that biopsy. So the Likert scale is different. It's a screening test. So staging is a complex process in prostate cancer. You would look at their PSA levels. Sometimes the higher the PSA, the more likely it is to be a diagnosis of prostate cancer. You would look in the TNM staging, so tumor node metastases. You would look at how kind of extensively the tumor is. And of course, you would refer them for an MDT input, which involves a lot of the members of the MDT, such as pathologists, which grade kind of how bad the tumor is microscopically, radiologists, radiologically, and clinical medical oncologists, which decide kind of what management options there really are. So the Gleason score is like a rating scale used to rate kind of how bad the tumor microscopically is. So they would usually take 2 samples to grade for the Gleason score, 2 biopsy samples, and they would rate each of the biopsy samples out of 5 and give them a score. So the first sample is usually the one that's more common and extensive, and the secondary sample is usually the one with less extensive. And so basically the higher the number for these groups, you would put them into the Cambridge Prognostic Index, which is something a bit more new, to assess the risk of prostate cancer. So the higher the index is, the higher risk you are for cancers. So 1 is considered low risk, 2, 3 is moderate risk, and 4, 5 is high risk. And we'll talk about the different management of these different kind of risk groups in the next slide. Yep, so for prostate cancers that have a low or intermediate risk, so they haven't spread that bad, or they haven't kind of gone very far, we would either opt for active surveillance, as in this case, because if a patient has less than 10 years of survival, we would opt for probably active surveillance or observation. You would also think about radical prostatectomy, so removal of the prostate, seminal vesicles, ampulla and vas deferens, plus or minus lymph node dissection. Sometimes it can be performed robotically, or you can do radiotherapy plus hormonal therapy. So radiotherapy is usually done over 7 to 8 weeks, and they would usually be dependent on how severe your cancer is. And then brachytherapy would be placing kind of radioactive seeds in the prostate, so the patient doesn't need to go back to hospital again and again like radiotherapy needs to. So both radiotherapy and hormonal therapy must be offered in intermediate disease. So a CPG of 2 or 3, you would need to offer that. So how do we manage kind of high risk cancers? You would radically remove the prostate, also their lymph node, and you can do that robotically as well. And you can also do radical radiotherapy with androgen, so hormonal therapy, and also, or with brachytherapy, or you can use chemotherapy, and that's with docetaxel. I'm not sure if that's how it's pronounced, but that's how I pronounce it. With anti-androgen therapy, so that's hormonal therapy. And chemotherapy is usually almost always reserved for metastatic cancer, and it must not be used alone. Okay, so someone's asked a very good question. How would you know about the life expectancy survival of a patient for active surveillance? So I'm not sure if all of you have been to a palliative care placement yet, but during my time there, they estimate prognosis based on kind of how well the patient is functioning and the rate of deterioration of their functioning and their bodily systems to estimate prognosis. So I agree with you, it's a very kind of expert decision, and it definitely wouldn't be the decision of a single person. It would usually have been kind of discussed in the MDT and really pass through multiple experts in order to arrive at that conclusion. So that's why kind of in common practice clinically, we would always refer someone with a suspicious query cancer to the MDT for discussion, for further management and treatment and diagnostic options. I hope that answers your question. Okay, so we move on to our top decile question. So we've got a 19-year-old man who presents to the emergency department with episodes of persistent, painful and unwanted erections that last up to 45 minutes. He states that these have been recurring over the past few months, usually at night, and he finds himself having to exercise to resolve these erections before going to bed. His last episodes resolved 20 minutes ago and lasted about an hour. He's got past medical history of sickle cell disease. What is the most likely diagnosis in this gentleman? So I'll give you guys a couple minutes to answer the questions. Meanwhile, I'll quickly go grab my charger. Okay, so we've got quite varied answers, and this is a top decile question. So well done to those who've attempted it. So the correct answer is stuttering priapism in acute sickle cell crises. So there are a couple types of priapism, which refers to kind of prolonged erections that are unwanted. There is non-ischemic, there's stuttering, and there's ischemic priapism. So ischemic and non-ischemic is very self-explanatory. Stuttering priapisms is usually refers to erections that last less than 1 hour to 3 hours, and they're linked to acute sickle cell crisis, which is in the past medical history of this gentleman. So priapism is one of the urological emergencies that we need to act on immediately. So the first step is to think about whether it's ischemic, non-ischemic, or stuttering. So ischemic priapisms usually kind of involve cardiovascular risk factors. It's kind of like a myocardial infarction, but in the penis. And there's non-ischemic priapisms, which are usually resolve on their own, and stuttering ones which come and go, as in this case. So some of the investigations you want to work up the type of priapism would be a Doppler study of a penile Doppler study that can help confirm kind of which type it is, but this should not delay aspiration and washout. So non-ischemic would indicate a poor arterial influx, and ischemic would indicate a high arterial influx and adequate outflow. So there's a blockage there somewhere. So you would do an FBC as well. These are kind of secondary investigations that you would do. A blood film, CT, MRI, abdomen and pelvis, and penile MRI in very refractory cases. The most important thing to know here is the management. If it's non-ischemic, you would manage it conservatively, but if it's ischemic or stuttering, especially secondary to sickle cell anemia, you would want to aspirate the corpus cavernosum, which is where the erection, the prolonged erection takes place, which is where the pathology is. And you want to do it in both diagnostic and therapeutically. So in a non-ischemic kind of priapism, you would see dark red blood, which is hypoxic, hypercapnic, and acidotic. And ischemic, because there's an obstruction of the blood flow itself that's very acute, you would see bright red and oxygenated blood. Does that make sense so far? Okay, I don't see any questions. So we'll move on to the last round of this session. We'll have a round of spot diagnosis, which I think is always the funnest part. So think about kind of, I'll give you a stem and think about what's the most likely diagnosis. It could or could not be something we've already covered. So this gentleman is a 99-year-old, referred to the AMU with increasingly frequent urination. He reports a stinging sensation when passing urine, and he was woken up last night by some severe right-sided flank pain. He's got past history of renal cell carcinoma, which he underwent a partial nephrectomy 12 years ago. So you examine him, you feel that his abdomen is soft with no guarding or peritonism, but he's a bit tender in the back in the right renal angle in the suprapubic region. His observations are stable, but he's slightly pyrexic, 39.4. What's the most likely diagnosis? So feel free to type it up and send it on the Menti So also a tip, try and think of the diagnosis that explains everything. That if you say this diagnosis, then you'd be able to explain almost all of the cues in this stem. Give you a couple minutes to think about this. Okay, so a few people have said pyelonephritis, which is a good guess, and I wouldn't say that this is wrong. I would definitely want to rule out or investigate a bit further if this gentleman has got pyelonephritis. Somebody said urinary tract infection, but they haven't specified if it's upper or lower. I'm hopefully assuming that they thought it was upper tract infection. But it's a good try. So the answer I was thinking was upper urinary tract infection, pyelonephritis, which is what you guys have got. Perhaps he's obstructed as well, and that was something I was just thinking. Perhaps something that we need to rule out as well by an ultrasound KUV, as we've spoken about earlier in this session. Well done. So the next two questions are about whether or not we want to refer this patient for a suspected cancer pathway. So we've got the first, which is a 64-year-old man who presents with dysuria and hematuria. He's got no significant past medical history to note, but he's worked in rubber manufacturing for 40 years. Would you refer or not refer? I know that we're running a bit short of time, so I'm going to speed up a little bit. So yes, this case is quite obvious. He's got unexplained kind of hematuria, and the majority of you have gotten it correct. We would refer this patient. And rubber manufacturing is a risk factor for bladder cancers. So definitely we would be referring this patient. So the next patient is a 66-year-old male who attends a GP appointment. He very embarrassingly states that he has to wake up almost 15 times every night to go to the loo. What is the next best step? Might be a longer kind of answer, so I'll give you guys a couple more minutes to type. I will answer the questions in the chat after this question, if that's okay. So we've got answers. some people have put urine dipstick, which is not a bad option, or HbA1c. That's a really good kind of thinking as well. That could be polyuria secondary to diabetes. Yeah, I would agree. But since this is a urological session, we would think about something more sinister, which is prostate cancer here. So you would conduct a PR exam, feel for the prostate, and also send a PSA to screen, which are the two criteria where we can do the 2-week wait referral, if you remember the flow chart earlier in this session. So we had a question in the chat asking why rubber manufacturing is a risk factor. I'm not sure what the chemical is called exactly, but I believe that if you work in rubber manufacturing for more than 3 decades or something, that you would be exposed to a carcinogen. I can't remember what it's called, but that basically increases your risk of bladder cancers. I'll try and find out after the session if I can find what that chemical is called, but we'll move on to the next question, which is on rectal examination, you can feel a hard craggy mass on this gentleman. What's the next best step? Yes, so someone's put 2-week wait referral. Brilliant. Brilliant. Perfect. So yeah, a brief kind of run through of the referral criteria. I won't take too long because I know that we're going a bit over time. So really any kind of 6 year over, you get non-visible hematuria or dysuria. Usually that would be after you dipstick the urine or raised white cell, or if you're 40 and over and you get visible hematuria that is recurrent or refractory to treatment of a UTI, you would refer them for a 2-week wait. Otherwise, you would consider a non-urgent referral. Prostate cancers, again, the 2 criteria that we've mentioned in the flow chart. If the prostate feels malignant on DRE exam, or the PSA is above the age-specific reference range. Otherwise, if they have any lower urinary tract symptoms, such as all of these, you would do a PR exam and send a PSA, as we've done in the last case. So yes, that's basically the summary. The high yield concepts I would think are BPH, renal stones, UTIs, pyelonephritis, incontinence, urological cancers, and the referral criteria, how to detect them as well, and some of the emergencies such as testicular torsion, urinary tract obstruction that we mentioned. Some of the top decile concepts are prostate cancers using the Gleason score and the CPG to just having a kind of good appreciation of how they diagnose prostate cancer and priapism as well. So that's about it for this session. Thank you so much for coming. I'm sorry that I took a little bit extra time to explain. If you have any questions, feel free to stay behind. And if not, please fill in the feedback form by scanning the QR code. And there will be kind of upcoming sessions on more different surgical specialties, but we'll be taking a short break over Christmas and November. But feel free to keep an eye out. I believe there are other kind of series of talks that are coming. So feel free to participate in that as well. Thank you very much for coming. Let me check if we've got any questions. Yeah, so these slides will be available on the Bite Medicine website, and I believe that they will be uploaded fairly soon, within these couple days. And if you guys have any further questions or want to get in contact with myself, feel free to DM me on Instagram or email me at this email. Thank you so much for coming. I hope you guys have a great evening. I will end this talk now. Bye.